can't reverse the clock, but I can inform people. Society has done a great job reminding women about, the fragility of their fertility. And I have people that come to me at 35 and they're like, oh my God, I'm turning 35 tomorrow. Am I going to fall off a fertility cliff? And that's not true either.
With a worldwide declining fertility rate, I continue to meet patients every single day struggling to get pregnant, looking for answers, and honestly, feeling hopeless. That's why I invited Dr. Sekhon onto the show. She is a double board-certified reproductive endocrinologist, an infertility specialist, and an OBGYN based in New York City.
There's an appropriate level of urgency because there is a clock, and contrary to what you might see in your Instagram feed, there isn't always a way to reverse that, or, there isn't like an easy supplement to take to fix that or freeze it. At the same time, it's on a continuum. It's not a cliff.
Yeah.
So I'll explain it this way. You're born with all the eggs that you're ever going to have. You don't make new eggs. You don't repair your eggs. I like to use this analogy of like a pantry. Imagine at the core of both ovaries, you have this pantry, the stockpile that you're born with, and every cycle you have an unlocking of the pantry in a situation that you can't control. I can't manipulate it as a fertility doctor, but a few of those eggs escape. And imagine they're like pulled out of the pantry into the kitchen cabinets. That's what I can see on an ultrasound. In bubbles of fluid that we call follicles, each one containing an egg. When I scan a person, I'm able to look at their ovaries and kind of get a count. And it's a cohort that is easy to count. It's like 10, 15, 20. It varies from person to person, but it's like rationing, which is why I use this pantry analogy, because the more you have in your stockpile in a given time frame, the more you tend to bring to the surface and bring out. But what really matters is, what is the chance of ovulating a healthy egg? And that's so much harder for people to understand because there's no direct way to test anyone's egg quality.
She helps individuals and couples at every stage of their reproductive journey. She wrote The Lucky Egg, Understanding Your Fertility and How to Get Pregnant Now, a clear, compassionate, evidence-based guide designed to demystify fertility for everyone and help people make informed choices. Please join me in welcoming Dr. Sekhon to the show. Okay, before we jump in, quick health check. Are you subscribed yet? You'd be surprised how many people forget the one click that actually helps them feel better every week. Go ahead, hit it. Around here, we turn science into self-care you can actually use. Let's get started. Dr. Sekhon, thank you for joining me today. This is such an important issue. I'm dealing with it within my family. I was telling you about my sister and kind of her journey, to colleagues, to patients that are coming in every single day, really struggling with getting pregnant. And it's not an age thing. It's, these are young women as well, women in their 20s and such. What's going on? Why is fertility so challenging? When we look at statistics, we know that the fertility rate is declining across the globe. And I know we can debate all the different reasons for that. But it seems like even when there's the intention, to get pregnant, it's such a challenge. I am so curious what you're seeing and what you think of all of this.
Well, when I first started out in my career, we used to use this statistic, 1 in 8 couples or individuals will have infertility. And now it's actually been recently updated by the WHO to 1 in 6.
Oh, wow.
And so I think you're right that it does seem like it's getting more prevalent. And I do think a huge factor is age for a lot of people, because we're seeing a major societal shift. Even in my own life and, my sisters, myself, my friends, it's very normal and commonplace for people to really settle down and start building their families more so in their 30s and beyond. Whereas our parents' generation and definitely our grandparents' generation, it was unheard of to wait till your 30s, right? To start building your family. And there's some good things about it. I think it's great that people know how to contracept and family planning is a thing. I do think people are not settling and they're waiting for the right relationship, the right situation. They're waiting to be financially stable. So all of that, though, does not line up with our biology.
Right.
And it can make it harder and more challenging. But as you said, it's not always age. And there can be other factors. Like a common factor outside of age is PCOS, polycystic ovary syndrome.
I have that. Our whole family has that. I've been talking about it ad nauseum. But
a lot of times it's how you're genetically wired, right? And there are certain populations, like I'm South Asian background, and so much type 2 diabetes and insulin resistance in my family. And so we do see certain demographics have more problems like PCOS. And a lot of it is genetic. Some of it's environmental. Some of it has to do with how, our bodies are wired from the diets that our ancestors had. And now we can't adjust as well to a Western diet. So there's so many theories, but that can cause irregular cycles.
Right.
And that is a major cause of infertility. If you're not ovulating or you don't know when your next ovulation is going to be, you're often not in the game when it comes to trying to conceive. And then there's definitely environmental factors. We talk a lot about, microplastics. There's a lot more awareness of how industrialization
has
and
affected us.
How we package our food and the things we're putting in and on our bodies, all of that can impact our health. And I don't think that we're ever going to have a full handle on, the gravity of all of these environmental exposures and how they can impact both male and female fertility.
It's such an important conversation to have because I do feel like the landscape of human biology, not to be too theoretical, is shifting. You know, I feel like when you talk about microplastics and you talk about some of these things, and we still don't yet have all the information to be super tactical in the exam room, right?
Yeah.
But we know we need to be aware of it. One of the things we can do, you mentioned like skipping periods or things like that, or, not having regularity, is at least educate young women to pay attention to that. Right. I think there's so many
red flags that go ignored.
What are some? Let's go into that though, because I think, for so long, you're going through your teenage years and your early 20s and you're busy.
Yes.
And, I wrote, in the hormone shift, I called them, the rock stars and the hustlers, because you're all over the place and you're burning the candle at both ends and you think you're kind of invincible.
Yeah.
And you're ignoring a lot of these red flags. So if we can get on the front end of that, what are some of the red flags that you would really...
I feel called out because that's how I'm leading my life these days.
Yeah, well, I did too, right? That's how I got in trouble. But
of course.
But
I think your period is like a fifth vital sign, right? For people that don't know what vital signs are, it's like your pulse, your blood pressure. These are all considered objective findings that you can gain some insight into someone's health. But people rarely think about their periods in that fashion.
Right.
And so if you have irregularity in your period, that could be a sign of medical problems like PCOS. And that can often be associated with a really ubiquitous problem of insulin resistance, which can lead to greater incidence of heart disease and all sorts of medical problems that can affect not just your fertility, but your overall general health and quality of life. But what about painful periods, right? It takes about 8 to 10 years on average to be diagnosed with a condition called endometriosis.
Mm-hmm.
And this is a common gynecological condition that affects up to 10% of women. That's probably undercalled because so many people are walking around normalizing their pain and saying, I might have missed a lot of work and maybe growing up I missed school because of my period. And I always have to tell them that's not normal.
Right.
It is normal that you're going to have some cramps, but I think it's hard for people to differentiate what's normal and what's not.
Is there a way to help people with it? Because first question, why does it take so long to diagnose endometriosis? And I know, the conventional answer is that you have to do a laparoscopic surgery, right? But has technology evolved at all? Has laboratory, like I read somewhere, doing a CA 125 might be helpful? Mm-hmm. Is there a way to get an earlier diagnosis? Because I know this is coming up over and over again.
Right. So endometriosis, for anyone that might not be familiar, is a condition where cells that behave like the cells that typically line the inner cavity of the uterus. So they're dynamic. They build up with estrogen stimulation and then they break down and you get a period. For some reason, cells that behave that way are found in other parts of the body. There used to be, the top theory of how this happened is that women, obviously when they menstruate, they have vaginal bleeding, but this can actually go backwards through the fallopian tubes and land in the pelvic cavity. And we know that all women have retrograde menstruation. That's what we call it to some degree. Your immune system should recognize when cells are in parts of your body that they shouldn't be. And it's like they come through like the janitor and clean them up, right? But we think about endometriosis as being this perfect storm. Not only might there be mechanical reasons like retrograde menstruation, and sometimes people with different shaped uteruses or uterine anomalies are more prone to that, right? So you do see an association. But why isn't their immune system recognizing these foreign cells? And sometimes it evades the immune system. So there might be an autoimmune component to this.
To that, right.
And it allows these cells to kind of set up shop. And if you think about what the lining of your uterus is supposed to do when a pregnancy is established, they're sticky and they're kind of invasive and they work with the embryo to allow it to burrow within and, turn into a pregnancy. And they can become sticky and invasive in other places. And they set up shop and turn into these, what we call implants. And they are able to respond to hormones. So every month, if someone's not on the birth control pill, if someone's able to ovulate, they have these monthly hormonal fluctuations that feed these implants. And then you also have, breakdown and bleeding and inflammation, and it can lead to scar tissue formation. So I always say no two patients with endometriosis are exactly alike. One of the reasons why it's hard to diagnose is it manifests in so many different ways. For some people, it means you see cysts on the ovaries very clearly that look like endometriosis.
Interesting.
For some people, their ovaries look perfect. It might be in the muscle wall of the uterus. These are examples where it might be obvious if you're doing a scan, but not everyone gets a scan, pelvic ultrasound as standard of care, which is a bone that I have to pick.
Me too.
Right,
Yes,
because you can learn a lot.
Right.
But the absence of those findings doesn't mean you don't have endometriosis, because it can be really insidious. It can be in the side pelvic wall.
Yeah.
And this is really weird. It can show up in the cavity that surrounds your lungs. It can even show up in the brain. That's not as
show
common.
Up in your lungs?
Yes. There are some people, when they get their period every month, they'll have like a lung collapse. Like, this is very rare, but it's
not a common one, but
it is a type of endometriosis. So it can look very different for different people. It doesn't always cause infertility. Not every person with endometriosis is going to have trouble getting pregnant, but for some people, it can cause blocked tubes. For some people, it can cause them to lose their eggs at a faster rate, or it can affect their egg quality or even the ability for the embryo to implant, especially if it's infiltrating the muscle of the uterus. So I think because it can manifest in so many different ways, it's hard to kind of pin down. I think also as a society and, the field of medicine has a long-standing dark history of minimizing women's pain and not adequately treating it. And I think women ourselves, we've internalized a lot of that and, don't often speak up for ourselves.
Right.
And even when we do, sometimes it's dismissed. So I think it's this vicious cycle that has led to this real delay in diagnosis.
Can we dial into the pain for just a second? I have a 17-year-old daughter, and I'm pretty convinced. In fact, I think we have our ultrasound appointments coming up, but I'm pretty convinced she's got endometriosis, just the way she presents. But there is pain that is crampy pain. You don't, you don't feel great, the week before your cycle or whatever. But then there's pain that is severe, and sometimes even signs. I always educate my patients like rectal pain and some of those things during your period are big warning signs or big red flags. Where is that like pain crossover where, okay, these are not just cramps. Yeah. We need to think a little bit more. Is there any kind of tactical or more like a less emotional, more logical way to like identify that?
There are validated pain questionnaires that researchers have used, because otherwise it seems like a subjective thing. Right. If you're trying to study different interventions, it's hard to compare. And it's not a perfect tool, and not everyone's going to have access to or know which ones to use. But I think the simplest thing for any layperson is, just keep a menstrual diary. Right. And a lot of times people will come to me and they're charting their information and kind of saying like, this is when I feel this pain. And it gives you a lot more objective information to go off of versus just depending on recall and being able to think back to, well, how painful was it? Because psychology is a weird thing where you can kind of minimize, past experiences, and it's almost like a defense mechanism. So I think keeping a diary, but it's a really challenging thing because everyone has a different pain tolerance or threshold. But I think if it comes down to interfering with your day-to-day ability to function. So that's why I always ask about like attendance when it comes to school or, calling out of work. Or having to modify your activities, like having to change your plans around your period. I don't think that's ever considered normal. And to go back to your original question, yes, the standard way to diagnose and the standard teaching has been you should do a laparoscopy, which is, it's invasive. Right. It's doing a small incision in the belly button and going in with a camera and looking directly instead of using ultrasound or other indirect ways of assessing, and being able to even not just see an implant, but to take a small biopsy, even send it off and say, okay, is this endometriosis? Does this look like the lining of the uterus instead of what it's supposed to be? And I don't think that that is always necessary as a fertility specialist. Our field, I can tell you, we used to do laparoscopies on so many people. And then they had these big studies that came out that were like, we're taking a lot of people for laparoscopy. Statistically speaking, you probably have to take like 30 women to surgery to improve, the fertility of one person. And that might not make sense. It might not be the safest approach for something that is technically invasive. It might not be a good use of resources. And I think that we can make the diagnosis clinically, right? If someone says to me, I have painful periods, here's my menstrual diary, this is how it's affected my life. And by the way, when I was on the pill for 5 years, all of this went away.
Wow.
And now I'm off and it's kind of back. I'm like, okay, well, that is a telltale sign. What else could that be? Right? You don't always need the proof, and you don't always necessarily have to have surgery. There's a role for surgery, but I don't think every single person that thinks they have endometriosis necessarily needs it.
I think that's pretty hopeful to so many people listening today, because I think that's a big block. Like, I don't want to go for surgery. Let me just put up with this for longer.
Right.
What about the CA-125, which is a marker, that I've seen some recent reports or literature on, is maybe using that and following and tracking that to see what's going on there. I love that you talked about sort of the autoimmune component of that. I think that's a lot of how I think about both PCOS and endometriosis. Like, we need to stop thinking about these as hormone diseases and think about them more as autoimmune diseases and look at things like inflammation. Curious if there's any marker or tracker that a clinician could use, or a patient could use, to sort of understand what's going on.
Yeah. So CA-125 is a test that scares a lot of people because the way it's traditionally been used is as a marker for certain types of ovarian cancer, but really it's a marker of inflammation. So if you have inflammation of your ovaries, often you're going to have really high levels, and it's used as a way to screen people. It's not the perfect screening tool. Ovarian cancer is a very difficult gynecologic cancer because it's often picked up at later stages. But for people with a strong family history, often they're getting, yearly or biannual pelvic ultrasounds and getting these levels checked. And if there's a rise, then maybe they, are watched more carefully. But we also know you can get these false positives, and especially at lower level elevations, there is an association between that and endometriosis. Now, I don't want to scare people who are listening to this and who are thinking, hey, I might have endometriosis, but it is a known fact that people with endometriosis can have a slightly increased risk of a specific type of ovarian cancer called clear cell carcinoma.
Okay.
But it makes sense because it can involve the tissue of the ovary. And so, you can test a CA-125, but if it's normal, that doesn't mean you don't have endometriosis. So I think that markers, there have been a lot that have been studied, like even BCL6, that's another inflammatory marker that a lot of fertility doctors nowadays are doing biopsies of the inner lining of the uterine cavity and looking for a certain level elevation in this marker. And some studies, not all, it hasn't really been validated.
What's the number? What's the
BCL6?
BCL6. And can we routinely test that or not?
You can. I mean, there's a company that will run it on a biopsy of the lining of the uterus, but there have been many cases of people that have said, yeah, mine was negative. And then I ended up going for a laparoscopy because I had all the signs and symptoms. And guess what? I had stage 4 endometriosis. So these markers are not perfect and they aren't as sensitive or as specific as we need them to be to truly say this can be part of the diagnostic criteria.
Gotcha. So still so much more work to do. So between endometriosis and PCOS, are those the two primary blocks to fertility that you are seeing in your practice?
I mean, we also see people with blocked tubes, right? And sometimes it's because they have conditions like endometriosis.
Right.
Sometimes it's because they had a ruptured appendix when they were younger and it led to like a local inflammatory reaction. So these are the things I ask people about when I talk about their surgical history, and they say, oh, I had appendicitis. I always ask, was it ruptured or not, right? I always ask about chronic medical conditions. There are some uncontrolled chronic medical conditions that can run concurrently alongside infertility or even recurrent pregnancy loss. So people with really poorly controlled autoimmune conditions where they're constantly having flares, that's not great for your general health. It's not going to be great for your fertility either.
Yeah.
Deficiencies. A lot of people don't realize that iron deficiency anemia can make it harder to get pregnant.
Are there other nutritional deficiencies that you've seen?
Vitamin D is a little bit harder to nail down the exact role, but there's many different proposed ways that it could impact fertility and pregnancy health. So I check everyone for vitamin D deficiency. And if I detect it, it's quite common, being in the Northern Hemisphere, especially going into the winter. It's something that I really keep my eye on, and I always replete it because you just don't want to have any unchecked deficiencies.
Are there genomics that you are tracking as well, or not necessarily? I don't know if you get into MTHFR or any of these sort of genomics that might have a higher risk?
So yes, we do. I mean, when I am working up cases of recurrent pregnancy loss, meaning 2 or more miscarriages, I often will look at, again, an immune marker that can also affect your risk of blood clotting. These are called antiphospholipid syndrome antibodies.
Okay.
And if those are elevated, there could be a role for giving baby aspirin while trying to conceive, and even a more potent injectable blood thinner called Lovenox once pregnant. Sometimes part of that panel, we'll look for other blood clotting disorders, even though blood clotting disorders are not really an established risk factor for recurrent losses. They often are on the panel that we use to run for ruling out antiphospholipid syndrome, which are 3 specific markers. And MTHFR comes up on that panel a lot. So, this is an enzyme that helps us break down folate. And there are many people, it used to be called a mutation, but now we talk about it more like a variant. And there are many people that have this variant.
Yep.
And it's not necessarily a problem. If you asked me or my colleagues like 10, 20 years ago, people would be like, oh my gosh, if you have this variant, like you need a different type of folic acid, you need to do this, you need to be on baby aspirin. Nowadays, we recognize that up to 30 to 40% of the population has a variant.
Right.
And there's so many different pathways for folate to be broken down that it's usually not a problem for people. Now, if there's a specific block that leads to backup of one of the things that's supposed to be broken down, backup of something called homocysteine, that can actually be a problem. So anytime someone has MTHFR tested for, there's always usually reflexive testing to look at homocysteine levels. And if those are normal, this is not considered clinically relevant in most cases. And it's a source of confusion because really and truly, we want people to take folic acid in their prenatal vitamin to prevent neural tube defects, problems like spina bifida. But there has been a lot of this like legacy information that is very hard to uncouple from this issue, where people feel very worried about taking folic acid. They want to take a very specific type, but that's usually not relevant. So if you have the MTHFR mutation or variant, then get your homocysteine level checked. That's the takeaway.
Follow that. That might be the big thing. And we've seen that in practice as well, with homocysteine being high, more inflammation in the body.
Right.
We don't necessarily track that in the cases of PCOS and endometriosis, but it is interesting to look at as well.
For sure.
One of the things I saw recently, and you probably saw the study too, is, and this is where it's so confusing for our women and for younger women. I'm all about having a career. I'm all about getting out there and doing what you're meant to do in the world, right? And I don't want women to think that they have to necessarily choose. But one of the things I saw recently was a study that talked about the rising rates of prenatal androgens in moms, in moms, like from a preconception standpoint and from an early kind of embryonic standpoint, and some of that being connected to, the early onset of PCOS and endometriosis and those type of things. I'm only bringing that up because if you could wave a magic wand, and I know we're going to get into more fertility stuff, but if you could wave a wand and say, I wish that teen girls and young women in their early 20s knew this, what would you say to them?
I mean, how many answers do I get?
You get 5.
Okay. I will say smoking is always a bad idea, right? We know that there are certain things that are fear-mongering, and then there are certain things that we know are exposures that truly can have a negative impact on our fertility, can accelerate how quickly we go into menopause, which technically means, how quickly our egg supply runs low to a point where our ovaries stop functioning. Smoking is one of those things. So this isn't to shame anyone, but it's to give you motivation that there's so many.
Does that include vaping, right?
So we don't have all of the studies that we do on tobacco and cigarette smoke, but it makes sense that there's an extension, right? And I think that this idea that e-cigarettes and vaping are like a healthier form of smoking, I don't think you can say that. I think you're inhaling, combusted chemicals. There's all sorts of toxins and things that you are ingesting that just aren't good for your general health, and they're not going to be good for your fertility. I think something else that people really need to recognize, not even just young people, everyone needs to be a little bit more aware of the role that insulin resistance can play in our health and in our fertility. And, when we talk about how to make our egg quality better, it seems like this magical concept. And often it is kind of used that way to market certain things like supplements. But the one meaningful thing you can really do to improve the environment where the eggs are maturing inside your ovaries that's where all the genetic reorganization is happening. When an egg is maturing, becoming ready to ovulate, actually going through ovulation and then fertilizing, those are moments where your chromosomes are being duplicated, rearranged, and they can be more error prone, those eggs, if they're in an environment that doesn't serve them. So if there's excess androgens, like excess testosterone, and a lot of that people don't realize can be linked to the role of high insulin levels, because your body's trying to get your cells to store sugars. So the insulin levels go up if your body tends to be resistant to those signals. And insulin can act like a growth factor on your ovaries. So I see it all the time where people are like, I've been tested for that. My hemoglobin A1C is normal. My insulin levels, all of these things are normal. But they have these indirect signs like high testosterone.
Yeah.
And we know where that's coming from. And then when we correct the insulin resistance, all of that seems to normalize. And I've had patients go through more than one attempt. Maybe they're coming to me for a second opinion, and they do seem to do a lot better when we get those things under control.
And as you mentioned, there's a huge, if you're of South Asian descent, even Hispanic descent, I think there is a huge epidemic. I don't know why. I don't know if you have any explanation, but there's an epidemic of insulin resistance at a young age. Not even like, later we can blame diet and this and that, but there is an epidemic of insulin resistance for sure. So I think it's so important to be aware of that.
One of the greats in the field of reproductive endocrinology, I'm proud to say that he was my mentor. He was at Mount Sinai. He actually passed away recently within the past year. His name's Nathan Case.
Okay.
And he's an endocrinologist who did so much work. He did a lot of menopause work, but he also focused a lot on trying to understand the origin, the etiology of PCOS.
Yeah.
And he talked a lot about these certain populations, and he talked a lot about immigration and how I alluded to it earlier, like our ancestors were in a different environment, eating a different diet, and that genetic wiring still exists in us today, and our bodies maybe aren't as equipped to deal with the Western diet as someone whose ancestors grew up in this environment, right?
Yeah.
So could this shift over time as we have now settled here and we'll have generations and generations follow us, in this environment? We don't know. I mean, there's so many other factors, but I think that is that is a major theory as to why it's so prevalent in certain populations.
That's so interesting. Anything else you would tell you? I love the insulin resistance piece. I think if we could get everybody to dial into that, how would you have them look at that? Because I've had those conversations with patients and they're like, same, A1C is fine, fasting insulin's fine. What's a better way to understand if that might be your block, that might be your fertility block?
So other labs that are kind of objective findings, like I mentioned, high testosterone, high DHEAS, which is another testosterone-like hormone that a lot of people don't know about. It's not as familiar as testosterone. There's another one that sometimes is elevated depending on the functioning of your adrenal glands. Your adrenal glands are little glands that sit on top of your kidneys on either side, kind of back here, and they make androgens. And so sometimes you can have this other androgen elevated called androstenedione. Some people are born with, a problem with one of the enzymes in their adrenal gland, and this can lead to an abnormal buildup of androgens. So there's a lot of different reasons or causes behind it, but we know insulin resistance can be a cause of a buildup of androgens. And so you can measure those. You can also do what's even better than a hemoglobin A1C, which is really just kind of an overview of your sugar control over the past 90 days, which a lot of people who have insulin resistance are churning out enough insulin at a higher level that they're able to compensate. So it's not that you're going to see an elevation in their blood sugar, but you might uncover it by giving them a glucose challenge and doing something called an oral glucose tolerance test where, 2 hours later, you're measuring their levels and seeing how did they handle that glucose load. And if it's kind of elevated, even if it's not diabetic range, that can also be a clue. But then other things that are kind of more insidious is asking about family history. So, I have patients that'll say, oh yeah, everyone in my family has type 2 diabetes. And you're like, okay. Or I've been gaining weight, and especially in my midsection, and it's been really hard no matter what I do. I just can't take it off. I have acne that seems hormonal. Like there's all these things that are tied together. Exactly.
Yeah. So interesting. And I really hope, if you're watching and listening, that you're spreading this information, because I think there's just so much heartache and frustration. And I feel like if we got, again, on the front end of it, then it would prevent some of the journeys I've seen so many different people take.
And sometimes there's a lot of really simple lifestyle measures. Like we know building up muscle in your body can promote being more sensitive to insulin.
Mm-hmm.
And conversely, having more fat deposition on your body, especially around the midsection, kind of opposes the effects of insulin. So just in our day-to-day behaviors and how we work out and treat our bodies, we can make a meaningful difference and we can prevent these things, which seem to get more common as we get older. But it's not always your fault. Sometimes you can do all the right things and you're still going to be wired.
The way you're wired.
Right.
And literally within our family, everyone's got high insulin.
Yep.
It shows up differently.
Right.
You know, I have one sister that has trouble with weight, another one that has trouble with like acne. I had trouble with hair. Like everyone's different, you know?
Yep.
So I think it's really important to understand and dial into that concept, you know, aggressively to get a handle on it. I'm curious, are you like an advocate for medications like metformin or the GLP-1s?
Absolutely.
Where do they fit into the conversation around fertility?
I think lifestyle changes are important and great, and they're not mutually exclusive with medications. I think sometimes people can find it really hard, especially to kind of kickstart the process. It's almost like, you know, you need some help, especially at the beginning, and then it becomes easier to see, you know, changes with lifestyle measures. So I think that it's a wonderful thing, especially in light of the fact that fertility is so time sensitive.
Mm-hmm.
I don't think it's a realistic goal to just say, you know, try to eat healthier, try to avoid insulin
calories
spikes.
In, calories out.
Right.
Like all
Sometimes
that stuff,
it's really difficult because you're already wired in such a way where high insulin levels can really bottom you out and make you have these periods of low blood sugar, where not only are you having major pangs of hunger, but you're feeling sick, you're feeling nauseous. It's sometimes really hard. You have to break this vicious cycle. And sometimes medication can be the best tool to do so. I have a lot of patients who take metformin.
Yeah.
And I tell them, you know, let's be doing all the things all at once because we want to make the most impact in the shortest amount of time, because we don't want to be, you know, only doing this and not focusing on the fertility. A lot of people are, you know, dealing with other time sensitive issues like a lower egg count. And so, and age and the effect it can have on their egg quality. So you really want to try and be as efficient as possible.
I like that. And some of the blocks that I've heard from folks too is like, well, I don't want to be on a medication forever, or
I'll become dependent on it.
I'll become dependent on it. Those are the two things I hear, but that's not the case.
No.
Like it's not the case.
It's not like your pancreas becomes lazy. Your pancreas is what churns out insulin. It's not like, oh, it becomes lazy because, you know, now you're just helping it along. That's not really true. I think your overall health can improve dramatically because insulin can be very pro-inflammatory.
Yeah.
And so, and I think it makes it easier to exercise. It makes it easier to be conditioned in a way where you can actually maintain a healthier lifestyle. So that's something that I really think is a huge mental block for a lot of people. Like, how long am I going to have to be on this? And I always say, I'm trying to get you pregnant, or I'm trying to improve your outcome, you know, for egg freezing or making embryos. And you don't have to stay on this long term, but I have some patients that are like, I feel so much better
on it.
That I actually do want to stay on it long term, even though I'm done with whatever I was doing with you. Can you please give me some refills?
Yeah. And I think these are all like actionable things that people watching and listening can take advantage of, right? So, you know, but that brings us now, okay, that's the preventive stuff. That's what you should be dialing into maybe early on. What about those people who have now entered the conversation around, I'm ready to get pregnant and are just struggling, and kind of the mind game, you know, is like, oh my God, you know, this is how old I am. I got to hurry up. If I don't hurry up, then XYZ is going to happen.
Yeah.
So the ticking clock, the time bomb,
that damn clock,
you know, help us with that.
Yeah. I mean, the best way that I can help, I can't make it go away. I can't reverse the clock, but I can inform people because, you know, I think society has done a great job. Maybe it's overperformed at reminding women about, you know, the fragility of their fertility. And I have people that come to me at, you know, 35 and they're like, oh my God, I'm turning 35 tomorrow. Am I going to fall off a fertility cliff? And that's not true either. Right. So I think that I have a very balanced view. There's an appropriate level of urgency because there is a clock. And, you know, contrary to what you might see in your Instagram feed, there isn't always a way to reverse that, or, you know, there isn't like an easy supplement to take to fix that or freeze it. But at the same time, it's on a continuum. It's not a cliff.
Yeah.
So I'll explain it this way. You're born with all the eggs that you're ever going to have. You don't make new eggs. You don't repair your eggs, right? I told someone that earlier today. who's in her late 30s, and she was like, oh my God, I've never heard that before. So I feel like even though it's not the most fun fact to share, it's an important one to be real about, that we just have different biology. You know, men have a biological clock too,
Right.
but they're always able to make new sperm.
Right.
Every 74 days or so, a new sperm cell is generated. We don't make new eggs. So we're born with a stockpile. And I like to use this analogy of like a pantry. Imagine at the core of both ovaries, you have this pantry, the stockpile that you're born with, and every cycle, you know, you have an unlocking of the pantry in a situation that you can't control. I can't manipulate it as a fertility doctor, but a few of those eggs, a very limited subset, kind of escape. And imagine they're like pulled out of the pantry into the kitchen cabinets and they're see-through, right? That's what I can see on an ultrasound. In bubbles of fluid that we call follicles, each one containing an egg, I'm able at any given time point when I scan a person, I'm able to look at their ovaries and kind of get a count. And it's a count, a size of a cohort that is easy to count. It's like 10, 15, 20. It varies from person to person, but it's like rationing, which is why I use this pantry analogy, because the more you have in your stockpile in a given time frame, the more you tend to bring to the surface and bring out. And then what your body does naturally once you go into puberty and you start being someone that can ovulate, your brain sends a signal called follicle stimulating hormone, where basically it sends a signal out, and like a lottery, one of these eggs is selected to mature, and it's a random selection, right? And then it gets matured and you're able to kind of open one cabinet or the other and access just one egg. One egg gets ovulated, everything else is a perishable item in those cabinets and gets thrown away. And then a new set come out of the pantry, right? So that is always kind of depleting our stockpile. We're losing hundreds to thousands of eggs each month in these waves of recruitment. And we don't really know why the system exists. And the reason why it's important to understand that this is happening in all of our ovaries, and people are walking around with no idea about this magic that's happening in our bodies. But you have to understand it, because this explains why when you ovulate one egg, your fertility is so inefficient, right?
Yeah.
That one egg is a long shot. It's not that you're ovulating. If people see 20 eggs on their ultrasound, they're like, oh, I'm so fertile, because they're assuming that now they have more chances to ovulate, but you're only ovulating one, and not every egg is going to be healthy and actually fertilize and grow into an embryo and implant. And you know, when we talk about numbers, the only reason it matters is because I, as a fertility doctor, do have the knowledge and technology and know-how to open both kitchen cabinets and try to the best of my ability to remove everything before it perishes and goes away. I can actually remove. And so the more you have available in the stockpile, the more you have available for me to take out.
Right.
And the more eggs you freeze, or the more eggs you try to turn into embryos, the better the treatment outcomes tend to be, the more efficient treatment tends to be. But ultimately, whatever egg count you have is not going to determine your natural fertility, your ability to get pregnant from one egg that's ovulated. So that's quantity and why it matters. It only matters if you need treatment, which you don't have a crystal ball. Maybe if you do, it's nice to know, hey, you have a lot of eggs that we can stimulate and access. But what really matters is, what is the chance of ovulating a healthy egg? And that's so much harder for people to understand, because there's no direct way to test anyone's egg quality. I wish there was a blood test where we could say, okay, 30% of eggs that you have at this current state could turn into healthy embryos. Right. That would be so helpful.
Yeah.
And we also don't have a test that tells us how quickly we're going to lose our eggs. We know that we tend to lose them at a faster rate as we approach 35 and older. So this is why that number is in everyone's, you know, at the forefront of their consciousness. They're like, oh God, I'm turning 35. Right. It doesn't mean you're going to lose all your eggs, but you will start to lose them faster. But the other thing that also happens at 35 is, it's never perfect for anyone. In your 20s, if I was to take all the eggs that I could get from the kitchen cabinets and turn them into embryos and tested them, even then, 20 to 25% of them are going to have typos or errors that don't allow those eggs to turn into babies.
Right.
That number rises to about 35% at 35. But then by the time you get to 37, 38, it's like 50-50. 40, it's more like 70% of embryos tend to be abnormal and not have reproductive potential, and 30% will be normal. So that's why turning 35 matters. It's not that all of a sudden you're destined to have infertility, age-related problems with egg quality and quantity. It's that it can become more challenging to randomly hope to ovulate a healthy egg. And this means it often takes many more ovulations to get to a pregnancy, and there's a higher risk of miscarriage when pregnancy does occur. But I always say, because I'm an optimist, you know, this also explains why some people will say, I got pregnant on my own without a fertility doctor's help at 42 because, hey, there's still 20% of embryos that could be normal at that age.
Do you believe we can reverse the ovarian age? I know there's a lot of work around PRP and stem cells, and I don't know what you think about that science. And I know it's probably—
I want to.
Yeah.
I would love that.
Yeah.
I would love that. Unfortunately, this is something I'm very much abreast of and constantly reading new data that comes out. Currently, there's no convincing evidence that any of those things work to do that.
Gotcha.
I think it's great that we're continuing to study it, though, because PRP can work in many different fields of medicine, especially for joint issues. Like, we know there are certain tissues in our body that you can actually cause regeneration of cells, and there is a real role for regenerative medicine, right? The ovaries are tricky because we just don't have that same ability to make new eggs. And so I'm not saying it's not going to be possible, but right now that is still very much in the experimental research phase. And right now, all of the data that has ever shown like a small associated rise in AMH level or egg count markers, it's probably more because of the disruption of the follicles. When you're piercing it with a needle and injecting it, you're creating an inflammatory response and then releasing more AMH coming from those follicles. We're not really seeing— there's 2 major randomized control trials, which is like the data we want, right? That came out in 2024. And before that, we didn't really have much to go off of. And both of them failed to show any sort of difference. Yeah. So I hope so. I think what would really be an amazing breakthrough, if any scientists are listening and are wanting to work on this problem, I would love if I could somehow program the ovaries to say, you know what? I know there's a low number in the pantry and we're bringing fewer to the surface as a result, but I'd like you to recruit more. Because then I could tell someone who's 40 and maybe dealing with a lower egg count, but also egg quality issues, yes, I'm going to deplete your stockpile faster. Because right now people worry about like an egg retrieval. Am I going to go into menopause sooner? And the reason why I go into this analogy is when you realize that whatever we're getting to would have been thrown out anyway, that alleviates that concern. But sometimes I wish that I could say, hey, this might actually deplete your egg count faster, your overall supply. But let's just, for this moment, to make sure that your cycle is successful, like let's start out with 30 eggs. I wish I could do that, and I feel like that's probably a more realistic path forward just from what I know about the science of the ovaries.
Regenerating the—
I think like just being able to access more would be a game changer.
Do you still like AMH and FSH-LH ratios and all that stuff as markers of egg quality?
I love all the information I can get.
Maybe explain what those are. FSH you've explained.
Yes.
Do you like the ratio to LH and why is that relevant? And then do you still like AMH?
I use all the information I can get, right? So AMH I love. AMH, anti-Müllerian hormone, is a hormone that's produced by all the little cells that line each of the bubbles of fluid that we call follicles. So I was mentioning how a bunch of eggs come out of the stockpile and they're visible each in bubbles of fluid. So the number that come out, obviously that's going to correlate with how much AMH is being produced by all the little cells that line each of those bubbles, right? So it's not telling you anything that different, but it's a different way of looking at egg quantity. Why do I like it? I think it helps me more than it helps my patients. It's harder for them to kind of interpret it with the right context. But for me, it really helps me figure out the right dose of medication to use to best stimulate their ovaries and how they might respond. It's also just nice to kind of compare. If someone has a lower response, you have this objective data point to say, oh, well, your AMH is different now. This is how it's kind of shifted. And so I do think it's a helpful thing because unlike FSH and some of these other markers that come from the pituitary gland, those get shut off if people are on the pill. And a lot of people are coming to me not necessarily with infertility, but for fertility checkups or to talk about egg freezing. And when they're on the pill, I can't necessarily check those other levels accurately, but AMH doesn't really get affected.
Gotcha.
I mean, long-term pill use sometimes can falsely suppress AMH, but that's not always the case. And in general, the teaching is you can kind of check it at any point in the cycle, whether or not they're on the pill, and you can get a gauge of their egg count. FSH is helpful because it tells us how hard your brain is working to stimulate the ovaries. And that's why as we approach perimenopause and menopause, we see much higher levels of FSH because essentially it's like your brain yelling at the ovary, telling it, come on, do your job, make estrogen. LH is another hormone that's produced by your pituitary, and it's the secondary signal once you have that mature egg that's been selected and grown by the FSH. It's the signal that really makes you release the egg. But a lot of women with PCOS tend to have higher LH levels, much higher LH levels than FSH. And while it's not part of the diagnostic criteria, I use it to figure out the right relative doses of certain medications. Women with PCOS going through an egg retrieval cycle typically need less LH and more FSH. And there are some women that have a different type of problem with their ovulation. Often it's women who've had histories of eating disorders, or maybe they're competitive athletes, any sort of situation where the pituitary might be a little bit stressed because of lack of energy or an energy deficit. It doesn't produce those same hormones. And you typically have too low of an LH and you actually need more LH. So I use this information to tailor my treatments on how to best stimulate someone's ovaries.
Such important information. I think this we've sort of established, but I want to make sure we drive it home. We know we can improve the egg's environment, or its home, right? Or where it's living, right? We've talked about insulin resistance. I know nutrients are a big part of that. I've talked about prenatal androgens. Can we really improve egg quality?
I think you can improve the environment where the eggs are being matured, and therefore you could potentially neutralize external sources of external exposures that would contribute more errors. I think the background risk associated with age is just, it is what it is, right? We're all subject to the effects of aging. You know, human beings have a specific lifespan. Like there's certain things that just can't be avoided, right? But we can live our lives in different ways that influence our lifespan. So that's the best analogy that I can think of, right? Like there are certain behaviors that definitely can lead to poorer egg quality or accelerated changes in egg quality. We've already talked about some of them, like smoking. And then therefore, there are things that you can do on the side of being healthier. And sometimes, you know, there could be a role for supplements. I definitely think correcting any nutritional deficiencies. And then there is some good data on CoQ10. It's not the most perfect data that we want, but enough observational studies and a lack of harm that kind of brings more comfort to say, you know what, there's some animal data. There's even some human studies that have been pooled and looked at where there seems to be a trend towards better outcomes, potentially better response to stimulation, potentially better quality of the eggs turning into embryos. And maybe it's a subtle change, but hey, let's do anything and everything that could help. So a lot of my patients take CoQ10. They usually take it at a dose of about 600 milligrams per day. But I don't think it should be touted as like the end all be it all, right? It's like, it's part of a larger strategy of just saying, whatever we can do, antioxidants, what do we mean when we talk about antioxidants? We talk about molecules that protect us from free radicals, which is one of the mechanisms of aging and cellular breakdown, whether it be because of radiation, you know, toxic exposures, cigarette smoke, like things like that. So I think it's a protective mechanism. Our body naturally knows what to do a lot of the time. Like we naturally all produce antioxidants, but you know, maybe some people are a little bit deficient and could use more. And I think if it's not going to do any potential harm, then, you know, if there could be a potential benefit, why not add it to your regimen?
I love that. And that's something that we see in practice a lot too, that again, that environment, whether it's insulin resistance, the high androgens, you know, nutritional deficiencies, those are things that we can actively work on while you're working on your fertility journey simultaneously. And many people finally arrive at that point where they decide to step into your office, right? You know, they've tried for a year. I think that's the standard. It hasn't happened for them. You know, what are some of the biggest fears, misconceptions, myths around what happens next, whether it's IUI or IVF or some of those things?
Yeah. I mean, first big misconception is when they walk through my door and they're looking to find a reason is, you know, there is going to be a reason that we identify very clearly and objectively, and then we'll have a targeted treatment plan. I think that's the biggest source of frustration in a lot of patients who are dealing with infertility is not really having closure or some sort of clear answer. But I always explain to them, there is no test for egg quality. And there could be something going on even at a younger age. We don't know for a fact that you're going to follow all of the standard statistics. And there could be other aspects of your partner's sperm quality that aren't necessarily picked up on a standard semen analysis, which is very basic. It's just saying you have enough sperm, there's a high enough proportion of sperm that can swim in a forward direction and that are shaped normally. but that doesn't mean it's perfect in all the ways that it needs to be.
Just
and
minimal requirements, just swim in one direction.
Exactly.
Right.
But we know chronic medical conditions, obesity, which can also throw off the testosterone estrogen balance in men. All of these things can have indirect impacts on sperm quality that you don't see, directly under the microscope when doing a semen analysis. So, I always explain that not getting an explanation, unexplained infertility, it's not a lazy diagnosis. It's just we don't have all of the tools necessary to really know everything there is to know. And a big blind spot is egg quality, right?
Yeah.
But it doesn't mean that there isn't a solution just because we didn't find a problem. So the standard workup is check to make sure there's no blockages in the tubes. Check to make sure there's no, mechanical things that could get in the way of an embryo implanting in the uterus, like fibroids or scarring or polyps. Make sure someone is ovulating, and make sure the sperm is healthy. Those are the 4 major components you're addressing. But if everything comes back normal, there are things that could be going on that you're not directly seeing. Endometriosis, not always obvious on imaging, right? Not always obvious even taking a history from a person because they've kind of normalized what their pain is. And there's some cases where you don't have so much pain. And that's also kind of a mystery too, that the severity of disease doesn't always correlate with symptoms. And then another big one is, like I said, egg quality, right? And then I always look at the person as a whole. Like, is there something else going on with their health that needs to be addressed that could be indirectly impacting their fertility? And if we find nothing, we're just trying to improve the inefficiency of human reproduction. There's really medicated IUI, which is essentially like speed dating for your reproductive tract. You're saying, okay, if one egg is expected to hopefully meet the perfect sperm and they get together, and the odds of all these things lining up is about 15, 20%, even in your 20s, early 30s, it's not that efficient. And you've already kind of given it a good run. Now let's bump it up a little bit. Let's give you a medication, an oral medication to improve the odds or the chance that you could release more than one egg or more than one long shot.
The Clomid.
Yeah, Clomid or letrozole.
Okay.
But then also on the sperm side, let's deliver the sperm closer to where the eggs are being released. So it's like speed dating. There's more eggs, more sperm, and you're hoping for an interaction. But anyone who's gone to a speed dating event knows you're not destined to meet the one the first time you go. It just might improve the odds of meeting that person, but it might take several cycles. So it's not the most efficient. And while it's not as burdensome on your body as, head-to-head comparison, one IUI cycle versus one IVF cycle, it can get fatiguing in terms of the mental game of doing something over and over and expecting a different result. So at a certain point, if that doesn't work, you move on. Or for some people, especially if they're starting their family at an older age or they have specific challenges, they might just go straight to IVF, right? And IVF is a different ballgame, a lot more work. You're taking shots for 8 to 10 days. You're trying to get all of those eggs in the kitchen cabinets to grow and mature because, like a banana, when it's ripe, is easier to peel. A bubble of fluid, a follicle that's expanding, it's easier to pierce and it's easier to remove the egg from each one when you're doing an egg retrieval procedure. So 8 to 10 days of shots, coming in for lots of check-ins. So there's a lot of poking and prodding. You're coming in for like 5 or 6 blood draws, ultrasounds during the 8 to 10 days. And then you're having a procedure, which is very minor. I've undergone an egg retrieval more than once. It's a great nap. You do feel crampy. You do feel groggy and out of it for the rest of the day. And it is normal to feel bloated, and everyone's different. But the large majority of patients, it's like that. It's a one-day thing, and the next day you can go to work, right? But what we're doing is we're extracting as many eggs as we can vaginally. And then that part is done. And then you're just waiting for updates. Maybe we freeze the eggs if you're doing egg freezing. But if we're trying to create embryos, the next day you'll know how many of those embryos actually fertilize successfully. It's typically like 70 to 80%. A week later, we'll know how many turned into embryos. It might be like half, maybe 60%. And an embryo has many cells, so you can remove some of the outer cells without harming the embryo. They would one day become the placenta, and you can genetically test them and freeze them and get a report back about 2 weeks later that identifies which ones are healthy and which ones are not. And that's one of the things that has made IVF much more successful. Even just putting one embryo back at a time, it's like a 60 to 70% chance of live birth. And it allows you to freeze extra embryos for the future and come back at any age. Your uterus doesn't really age.
So you could potentially do an IVF or an embryo transplant up to what age? Where would you?
There are no hard and fast rules or limits, but every clinic kind of has their own ethical guidelines. And we do look to the American Society of Reproductive Medicine, and they do give some guidance, but there isn't like a black and white, because patient care should be individualized. So I
Right.
want to make that clear. But in general, yes, we can get people pregnant, and their ability to get pregnant and stay pregnant, meaning the risk of miscarriage, should not be affected by the age of their uterus, which is pretty miraculous. But the obstetrical risks, meaning like the risk
Delivery.
of risk of high blood pressure, the risk of diabetes in pregnancy, risks to the fetus, all of these things are heightened as we get older.
Yeah.
That risk starts to set in at 35 and older, but it doesn't mean every person over 35 who's pregnant is going to have a complication, but your chances increase and you're watched more carefully. And that becomes even more true in our 40s, and definitely even more true over 45. Like that every 5 years is a very significant increment of time.
Gotcha.
But if you're someone that is not overweight, you have well-controlled conditions, or you're healthy, you don't have any medical conditions, those are all things that are in your corner to promote, being able to have a healthier pregnancy.
Yeah.
But age in and of itself can cause wear and tear, especially to your blood vessels, right? And so you're more prone to things like high blood pressure.
I do know 50-year-olds who have carried.
Yeah. I mean, I would say most practices will say 50 might be the limit, or even up to 55 if you're in perfect health.
Gotcha.
But you will hear crazy headlines that are true in other countries where there's less regulatory oversight of women having children in their 70s.
Wow.
But, you have to think about the ethical dilemma surrounding that. I think the guidelines from the ASRM is very much, surrounding not just the health of the mom and the health of the child, but also, can you reasonably, as a couple or as an individual, be around to raise your child to adulthood, like age 21?
Right. What does the future look like for IVF and assisted reproduction? Is there anything on the horizon? Is there anything new developing?
Well, I think we've made remarkable strides. My mentors who were around when IVF was invented, which was really in like the 70s, which is crazy to think of. That's not that long ago. Back then, they used to say, there was like a 5% or less chance of calling a patient with a positive pregnancy test after doing IVF. And they were putting in multiple embryos, and they didn't know how to freeze and thaw them well. They did not know how to do genetic testing. And now we're at a place where I'm hardly ever putting in more than one embryo because the success rates are so high. It would just really increase the risk of twins, which is a high risk pregnancy. And we're able to say, okay, within 3 transfer attempts of one embryo at a time, if it's genetically tested, there's a 92% chance of live birth.
That's incredible.
Yes,
and
it
hopeful.
is. Very hopeful. So I think we've already made a lot of progress. I think what's going to close the gap, why do 1/3 of high quality, seemingly perfect, genetically tested embryos not implant? Because the testing is not exactly perfect. The testing is very good, but right now we're just sampling a small number of the cells that actually make up the embryo. And I think if we could find a way to like collect some of the media around the embryo and get a more holistic view, and once the resolution of the testing gets even deeper, we're going to know more and be able to better select which embryo to transfer. So I think that will probably close the gap and make success even better. I think finding ways to overcome some of the difficult problems, like I said, being able to make more eggs come to the surface. Like right now that feels like sci-fi, but it doesn't seem like that crazy of a thing for us to figure out. So I hope that becomes something. And I hope, for women that have scarring in their uterus.
Right.
Going back to the idea of regenerative medicine, like finding ways to help them regrow their lining.
Clean the lining up for
preventing problems, like being able to prevent fibroids, being able to better prevent, things like PCOS and endometriosis from getting worse.
Do you want women, this is a debate, but do you want women to make decisions like, okay, I'm busy right now, I'm focused on something else right now, I'm going to freeze my eggs for later?
It's not that I want them to do that. I want everyone to think about their life goals. And I know that sounds so like wishy-washy, but as a professional woman, as someone that actually did take a moment and froze embryos, I froze embryos with my husband at 34 after having my first. And I know for a fact, I know myself well enough to know that I never would have done that or made the effort to do it had I not been in this field. I was just too busy. It would have been like such a peripheral thought to me. And I would have been like, it's probably all going to work out. Even if I was in medicine, I can admit that to myself, right? But because it was in my face, I was like, I need to really strategize this. And even still, I was kind of in denial. I was like, I probably will never use this. And guess what? At 38, it was a lot harder to get pregnant. I ended up needing to rely on what I froze. So I was really happy that I did this proactive thing. I know that in my career and just how busy, you were saying like, I can't believe you just came from seeing patients. It's like we're running on empty a lot of the time.
Right.
And I think it's very easy, and I see it in a lot of my patients that are in high-powered careers, to just go, and never really take a beat to think, hey, what am I doing in my life? What do I want out of life? Are my actions aligning with what I actually want? It's really easy to be the hamster in the wheel.
Yeah.
Yes. And time goes by and you get another promotion and then like it just slips away from you. So I think people need to take the time to think about their goals and prioritize them. I think they should learn about the option to freeze eggs or freeze embryos. And, sometimes it's just having the conversation that opens their mind up to even the possibility. There's a lot of preconceived notions.
Right.
Sometimes people come in and they're like, I know egg freezing doesn't really work. And I'm like, what are you talking about? It can work really well.
Yeah.
It's just never a guarantee because an egg is a single cell in your freezing potential, but it can give you a massive head start if and should you ever need IVF.
I think that's incredible. And I do think, I talk about the superwoman syndrome and I agree. I want women to be out there doing what they want to do.
Yeah.
I think one of the things that at least our generation has learned is that we have to balance our energies. And that includes our feminine fertile energy, right? With all the goal setting and all the things that we want to accomplish in the world. And I think that it's incredible that women have options today. But I think it begins with thinking about your health, and it begins with thinking about all the determinants of your health and how that ties to fertility, and then what you're going to do from an actionable standpoint in terms of safeguarding your health and safeguarding your fertility, and then knowing what you're going to do next. And I think that's just a really important conversation to have with yourself. You know?
I think a lot of people suppress thoughts about fertility because it brings up anxiety.
Yes.
And it also brings up like an existential crisis. And often people feel very helpless because they're like, well, only when the relationship comes, then this becomes a priority. And I don't think that that's how it has to be.
And that can also feel like failure, right?
Yes.
Well, I'm not able to find the person, or I'm not able to do whatever. And then there's just this, again, that shame that women already have had to live with for centuries. Like, I think it just, emphasizes that feeling again, and there's no reason, be logical about your fertility and your health, just like you would about your career.
Yeah.
And let your relationship grow emotionally and maybe illogically like it's supposed to. You know what I mean? So it's, I think, understanding that there's a difference between those two determinants of your life,
There's also a huge difference, in what we're taught growing up and what we see happen when it comes to education and our career goals, where the amount of effort you put in equals the result.
Correct.
When it comes to relationships, it takes two. And you can't control everything that happens in that arena. And same with fertility. There's so much that's out of our control that it's not a meritocracy. It's not like you put in the effort,
you get
did the work. Exactly. And that's hard for people like us. That, that's like what our career has been built on.
Yeah, very much. Well, your book is coming out, The Lucky Egg.
Yes.
Talk to us about that.
So this is a book that was born from years in practice of patients asking me, is there like a one-stop shop resource that I can go to which will help me navigate this crazy 180 shift that only women, it feels like, are expected to do? Like, you go through your life like, I don't want to get pregnant, and now all of a sudden you're not equipped with any information, and it's like, okay, buy ovulation predictor kits and figure out your cycle. And everyone's like, oh my God, I have no idea what's going on. And I meet women who are so smart, so talented, so successful. They're in their 30s, they're in their 40s, and they don't know the basics.
Yeah.
And so this is to fill that knowledge gap.
Love it.
But it's also to provide like a dictionary. There's even a glossary at the end, because I always say, getting into the world of fertility, if you do start running into trouble, like, what do these tests mean? What are the treatment options? It feels like learning a new language.
Yeah.
And so it's almost like, a fertility English dictionary of sorts to help people just really navigate, this transition from not thinking about it to all of a sudden it becoming really important to them. And knowing that it's time sensitive and you want to be efficient with your time and not get pulled in all these different directions and, with all the noise and bad information. So it's evidence-based, it's warm, It's not going to make you feel like a science experiment.
Yeah.
It is going to make you feel like you have a best friend that is also a fertility doctor.
Love it.
That's here to hold your hand and guide you through every step of the process. And there's also a really huge part of it that is about mental health, because one of the major contributions, I should say, to people not getting to the success, to the finish line, especially in a time where IVF can be successful for a lot of people, is often premature dropout. And they've even looked at this and looked at, like, is it financial? Obviously, there can be financial barriers, but the number one contributor to premature dropout is psychological, the mental burden, right? So I think really paying attention to your mental health alongside your physical health so that you can stay in it to win it. And then also there's a whole section on troubleshooting, because I think that's where people really get tripped up when they have a failed cycle and they're like, now what do I do?
Yeah. I love that. It's such an important resource. I know so many of you will benefit from it. Where can people find you or find the book, or where would you direct everybody to?
So the book is going to be sold wherever you can find books, right? Yeah. And you can go to my website, theluckyegg.com, and the landing page, you can pre-order it at various places. That website is also a great resource. I have a lot of like AMH calculators, egg freezing calculators, really practical tools alongside blogs and content that will help kind of explain a lot of important things about testing and treatment. And then I'm on Instagram and TikTok, so you can find me there. I try to, make light of things and bring a lot of levity to something that can traditionally feel very anxiety provoking or fearful, because I think that, education is at the core of what we really need to be pushing forward.
Yeah. Well, thank you so much for taking time out today. This has been such an incredible conversation. I'm going to ask you one final question.
Sure.
What makes you whole?
What makes me whole? Honestly, I would have to say, I think having a purpose in life, having a mission. And I know that sounds so general, but I really do feel gratitude every day, knowing that I'm doing exactly what I'm meant to be doing. I feel so driven and passionate about this mission. I grew up in a matriarchal household and in a culture where, women didn't necessarily get prioritized.
Right.
And so for me, it feels so gratifying to be in this role, educating women, empowering them, giving them options that like my grandmother could never have dreamt of, and just making people feel like less afraid, more seen, and more in control.
I love that. Purpose I can resonate with that so much. So thank you again for taking time to be here today. I really appreciate it. And for everybody else watching and listening to this episode, please remember to share it with your friends. And if you have somebody in your life who is in that space, right? That space where they're feeling discouraged, shameful, hopeless, please share this episode with them. I know I have met so many people in my journey who have been there, and I wish I could have shared this with them earlier. Thank you, and I'll see you guys next time. All right, before you click away, don't forget to subscribe. It's free, and it helps more people find Whole Plus. And if you're already here, why stop now? Watch the next video right here on the screen. It's one you don't want to miss.